Thank you so much for tuning in. Again, my name is Christina Sire with the Iowa Maternal Health Echo Series, and today we'll be talking about perinatal mood and anxiety disorders and what to do when a pregnant individual screens positive for a disorder. I'm really excited to introduce our subject matter expert today, Dr. Bailey Brooks. Dr. Brooks is an Iowan native and attended medical school at Creighton University in Omaha, Nebraska. She completed her residency training at the University of Iowa and also completed an away rotation during residency at Pine Rest Mother and Baby Day program in Michigan. She has a strong interest in perinatal and reproductive psychiatry and is currently an outpatient psychiatrist at Broadlawns Medical Center. She sees perinatal patients embedded in the OBGYN clinic as well as staffs the resident perinatal clinic. In her free time, she loves spending time with her family, and we are honored to have you here today, Dr. Brooks, to guide us through a very rich and complex topic. So that's all that I have to share for this time being. So feel free to take it from here. Thank you.
Thank you so much. I told Christina I have not had the honor of attending an echo before, so you guys will have to give me feedback afterwards. And I am excited to be here today. This is a little bit of a complex topic, and so my understanding is the biggest need or want for this didactics was really to go over like what to do with a positive mental health screen. But I also think it's important to touch on like a few other things as well as we get into that. So we're just going to do like a brief overview, talk about some risk factors, the screening, and then also evidence-based treatment, and suicide risk implementation, and then a few special scenarios of bipolar disorder and postpartum psychosis. And then I did try to put together some resources for providers and then also some resources that I give patients because sometimes that can be very helpful as well. And then we will go over the cases that you guys came up with. So just like a very brief overview, some of the statistics get a little bit confusing depending on like what you're looking at, but in general, we think that 1 in 5 perinatal patients experience depression and or anxiety. About 20% of patients are affected by depression. Anxiety affects up to 15% of these individuals. And then OCD is something that we also talk about quite frequently. And the numbers kind of change, but during pregnancy, that can be up to 8% and postpartum up to 17% of individuals. So it's quite a bit. And then we also think of like birth trauma related PTSD, which also can be around like 3% of people. So this is very prominent. This is very common in the patients that we see. And something during my training, like a quote that I saw, I thought was pretty powerful is that perinatal mental health and substance use disorders are common, undertreating, and the leading cause of maternal mortality in the United States. We know that postpartum mental illness is actually the most common complication of childbirth. So this is really important. Not to get like too much into nomenclature and whatnot, but I do think that it's a little bit important to point out that like when we use the DSM in psychiatry for diagnoses, I think there's an issue with the peripartum specifier. So typically that means like during pregnancy and up to 4 weeks postpartum. But we know that the reality is that people that struggle with perinatal depression can actually have symptoms like up to 3 years postpartum. So only looking in that time frame, and especially when we're talking about screening, what to do with those screens, we kind of have to think a little bit more than that. And especially because suicide and overdose deaths are actually most common 6 to 12 months postpartum. And so sometimes that also gets tricky too when we think about screening because oftentimes people have their postpartum check it with OB, but then if things are well from like an obstetric component, then maybe they're not being seen again by OB as well. So I do think it's important to point out a couple of those things. And then also, before we talk about like screening and what to do with it as well, considering some risk factors for perinatal mental health is important. And so what I, talk to patients about very commonly is that depression or anxiety during pregnancy is the best predictor of postpartum depression or anxiety. And so that is why we also want to screen when we screen and what the recommendations are. Um, Prenatal anxiety, so anxiety during pregnancy, can also be a large risk factor for developing postpartum depression, even if maybe depression wasn't something they experienced in pregnancy, but if they're very anxious during pregnancy, that's also a risk factor. So kind of being aware of that too, maybe like during visits, if you have that sense, any history of like postpartum depression or postpartum anxiety is a risk factor, in addition to just known underlying mental health disorders. Um, Medication discontinuation is a huge risk factor for relapse of symptoms. So in bipolar disorder, 50% of patients are going to relapse by 10 weeks of gestation if they discontinue their medications. And so that's why we're also talking about what to do with a positive screen as well. 50% of people with major depression disorder are going to relapse by 16 weeks. So that also just shows bipolar disorder is very, very high risk in pregnancy and postpartum. Um, Things that have been looked at more recently too is like a history of mood changes with oral contraceptives is also a risk factor for developing postpartum depression. So that's something to consider if you knew someone before they got pregnant, they told you they really struggled with an OCP historically, that might be something to be aware of if you're now following them during pregnancy or postpartum. And then there's a bunch of other risk factors like stress, things that make sense, right? Like stressful life events, marital dissatisfaction, inadequate support, stress related to childcare, difficult infant temperament, low self-esteem, a family history of postpartum depression, unwanted or unplanned pregnancies, which is also very important to address because about 45% of pregnancies are also unintended or unplanned, lower socioeconomic status, being single. And then there's some evidence for the postpartum baby blues, but the caveat to that is that postpartum baby blues is very common. And just a side note to that, intrusive thoughts are also very common. So we kind of have to differentiate like postpartum baby blues, normal adjustment to motherhood, intrusive thoughts that are quite normal versus like psychopathology that needs to be addressed, which is hopefully observed in a screener. So with that, on to like the bigger portion of today, screening. So ACOG has their own recommendations for screening, and their clinical practice guidelines are really great too. Just throwing it out there, like as a psychiatrist perspective, when I read like clinical practice guideline 4 and 5, I'm very impressed by the recommendations in that. And so they recommend in screening at the initial prenatal visit, later in pregnancy, and at postpartum visits. There is some recommendations for screening, like once at the first visit, once in the second trimester, again in the third trimester, and then that 6-week postpartum visit or the first postpartum visit, and then also 6 to 12 months, either both, one or the other, either in the OB or primary care setting. And then obviously we're also hopeful that at the pediatric visits, pediatrics is also screening moms at like the 3, 6, 12-month visits as well. But it also gets tricky with coordinating care. Something that I did want to point out here on these guidelines from the ACOG is that it does say screening for bipolar disorder be done before initiating pharmacotherapy. And we're going to touch on that in a few slides because I think that's really important, but I also don't want that to be ever something that makes someone nervous to screen or necessarily like be scared to treat with a positive screen. So now we did the screening because we are doing a really good job at implementing those screens, which is great. But now what do we do with it? And so some things, from a psychiatric perspective, that I think is always important and sometimes missed is that ruling out medical causes. So especially maybe for someone that doesn't have a psychiatric history, maybe they don't have as many risk factors, considering checking like a thyroid. We know that pregnancy postpartum can be high risk period for like thyroid abnormalities to come about. Also, ferritin, like low ferritin, low iron can really affect people. Sometimes, if someone had, a lot of bleeding during birth, things like that, it can also affect them. So, those are just some labs that we could always consider checking, especially if you're checking labs, anyways, at a postpartum visit. I always tell people I don't know what insurance is going to cover versus not, but I still think there's an option to have those things tested if the patient wants to. Then going forward from that, the big thing is that this is like a risk versus risk conversation. So I think the most important thing is that um, we know that there are risks of undertreated anxiety and depression or bipolar illness, and that risk is actually very significant. And sometimes I think the emphasis goes on like maybe the medication as that risk or that exposure rather than the known risks of these undertreated mental health conditions. And so I think if we frame that to patients, because oftentimes these patients also have reservations or concerns about the ability to take care of themselves or use medications if they're pregnant or if they're nursing. And so I think we have to frame it to them as considering like this illness as an exposure because we know undertreated, it can cause poor engagement in medical care. Maybe they're not coming to their OB visits. It can cause exacerbation of medical conditions. It can increase like the risk of smoking during pregnancy or early postpartum, substance use disorders. It also can affect like obstetrical outcomes like preterm birth, low birth weight, and also it can also affect like the risk of maternal suicide and also have neonatal and infant outcomes as well. Something that is important to consider that maternal mental illness can be considered as a toxic exposure and also can increase the risk of adverse childhood events in the offspring. And that can also be an important predictor of later psychopathology in the child too. So these undertreating or not treating is a risk. So then we talk about the potential risks of medication. And so what I always talk to people about is that, the hope is that we can avoid to exposing the fetus or the infant to both untreated or undertreated mental health and medication. Okay. And so the goal is going to be remission and or prevention, depending on like what exactly we're picking up on the screen. And so specifically maybe more so for this audience is that if we know that someone has been on medication before and it was effective for them, then use that, like use what was effective before. Because this also helps avoid multiple exposures. So if maybe you try something that's maybe has a little bit more data, but then it's not effective, then you're going to end up exposing to both the medication now and the medication before. And then we also use the lowest effective dose, but the primary emphasis is going to be on effective. So it doesn't make sense to expose to both medication and undertreated mental illness. We really want to use the dose that gets us to euthymia or adequate control of anxiety. And, some people still might be very, very reluctant to engage in medication, even after you did like a wonderful risk conversation. Or maybe their symptoms aren't as severe that maybe they need medication. And so we can talk about the non-pharmacological interventions as well, such as psychotherapy, which can be extremely effective on its own and in combination with medication. Talking about good exercise, good nutrition, having adequate support, which can be really, really hard for people. And also like breastfeeding support. And sometimes or just giving people, empowered to make the decision that's best for them. Like instead of triple feeding for months on end, maybe being the one that says it's okay, like it's okay. Or helping connect with the lactation consultant or something along those lines. Um, and then the biggest thing really is sleep. And some of my patients oftentimes, like, we laugh about it, right? Because an infant and sleep don't necessarily belong in the same sentence. But, if someone does have support, there is a way that mom can get 4 to 5 hours of uninterrupted sleep, which can make a huge difference in their mental health. And so I think we can't under recommend the importance of sleep, and also acknowledging that it's hard with an infant. We can do both. So let's say, we have this positive screen, we have this conversation. Mom does or does not choose to proceed with medication. I still think like follow-up is important. And especially if we do start a medication, which we're going to come back to in a second, in about like a month, or referring to psychiatry or referring to primary care for ongoing care. Like, someone should have that follow-up to make sure things are going okay. Another just thing that I'm passionate about is, like, you guys do a really great job, but also discussing contraception, because we know many pregnancies are unplanned. And if someone's already struggling, to just opening that door for that conversation. And then this is technically not what to do with a positive screen, but as far as what to do is, let's say that you have a return patient, like, you delivered their last baby, they're pregnant again, and they really struggled in the postpartum period. Like, maybe they weren't seeing you often, but maybe they scored high on a screener postpartum, and then, maybe they sought treatment, maybe they didn't. I don't know, but that. And so they're coming back to see you. Maybe you do a screen again. Maybe you haven't done the screen at that appointment. I would recommend that you ask them, do they want to see like a perinatal psychiatrist? Do they want to see a psychiatrist, just to even discuss like their past history, recommendations going forward? It can be very helpful to have some of these conversations before someone becomes pregnant, or before they're in like the throes of postpartum, which can be really difficult as well. So that's just a little note on that. So like maybe what's more helpful is to actually talk a little bit more about medications as well. And so I think, the biggest thing is that stopping medication is not the standard of care. Historically, people would stop medications, or patients would stop them on their own because they didn't know what to do with them. But really, that is not recommended anymore. Obviously, we want to limit exposures to the fetus if we can, simplify things if we can, but just stopping medication is not what we typically recommend anymore. A couple of other things is that depends on when you do the screening, but if someone scores elevated during pregnancy, you start a medication during early pregnancy. Oftentimes, the physiological changes of pregnancy will require a higher dose of medications in the second half of pregnancy to get the same therapeutic effect. So it's not uncommon, like maybe someone was really stable and then all of a sudden you see them third trimester and they're tearful and they're worried. It might be just because they need to have an increased dose of their medication to get the same therapeutic effect as previously. And then there's really few psychiatric medications that have an absolute contraindication in lactation. So that's good news and something just to keep in mind as well. So if someone screens positive for postpartum anxiety, postpartum depression, obsessive compulsive disorder, PTSD, if they've never had any prior medication trials, it is reasonable to start with sertraline, which has the most data in pregnancy and lactation. If they've tried that before and it wasn't effective, Lexapro or escitalopram would be my second choice. And if they've tried both those things, like, I would consider fluoxetine as well. The note about fluoxetine is that it does have a longer half-life. And so in theory, that could affect the exposure. And then especially through nursing, like with the longer half-life, it does have, it might build up a little bit more. However, if someone is doing well, they are stable on fluoxetine, I would never take them off of it because of that. It just wouldn't necessarily, if I was on a clean slate, no medication trials, I wouldn't choose fluoxetine first. And then a few other important things that I like people to know about is that I will often initiate at half the lowest dose recommended, because even though we're treating for maybe anxiety, sometimes initially starting the medication can cause a transient increase in anxiety, and then that can make people very reluctant to continue treatment or be scared of treatment in the future. And so, with depression, we talk about like starting sertraline or Zoloft at 50. I will always start at 25 milligrams. And then I titrate that pretty slowly with, giving the patient the ability to titrate that a little bit faster if they're not noticing any side effects. It's always my pregnant and my postpartum moms that struggle with insomnia with antidepressants if they're going to. So I always tell people to take it in the morning. And then if they are really sedated after a period of time, we can switch it to bedtime, but I almost always tell them to take it in the morning to start off. The other big thing to consider is that oftentimes with anxiety disorders or OCD, we have to go to higher doses to get a therapeutic effect of medication. And so sometimes that also causes maybe like some hesitation with patients or concern with providers, but that's not uncommon for us to see. And the other thing too is I always talk with patients about oftentimes patients were reluctant to maybe engage in like medication in the first place. And so sometimes that also might mean they want to come off medications as quickly as possible. So maybe they're on it for a few months, they feel better, they're ready to come off, and then their risk of relapse is pretty high and they're still in this vulnerable time period. So I typically tell people at the time of prescribing medication I would recommend being on it for at least 6 to 12 months on the dose that got them stable in remission before considering discontinuation. If medication was stopped during pregnancy, consider starting it in late third trimester or postpartum, because it can also take 4 to 6 weeks to become effective at the dose prescribed. So unfortunately, medications take time to work, and that's hard when things are already feeling very hard. Another big thing to think about is if someone's screened positive in pregnancy and they're on medication, sometimes patients ask, well, should I stop medication in the third trimester to prevent those like withdrawal-like symptoms, which we know is transient neonatal adaptation syndrome. And that is not the standard of care because we're going into this vulnerable time period. And we know it takes time for medication to work, that we continue medications as prescribed, even in that third trimester. A few other just quick notes about medication is so zuranolone, the newer medication, right? This is a 14-day oral treatment course, and the studies have shown benefits by day 3, which is a huge deal because I was just talking about how SSRIs or SNRIs, antidepressants, take 4 to 6 weeks to become effective. So the data shows benefits by day 3. However, there's a lack of data with breastfeeding. So a lot of people are going to recommend to not breastfeed, and sometimes that's not in line with someone's goal, or just discussing that there's not a lot of evidence for breastfeeding, and so the safety data is really unknown. One of the biggest side effects, though, with zuranolone is sedation, and so that also can be problematic if someone doesn't have overnight support to help with baby. I don't use zuranolone often. Honestly, I haven't had patients that have had like a super positive effect with zuranolone. Granted, my like N is pretty low, but the data does show that there can be benefit, but I think there's also a lot of limitations and barriers with, potential sedation, potential lack of support, potential desire to breastfeed and not want to take the risk of the unknowns. But that is available, which is good to know about. It does usually, or does not usually, it does require being sent to a specialty pharmacy. But if you know what the specialty pharmacy is, I haven't had any issues with getting it approved. So that's nice, at least. If a patient is needing an antipsychotic for any reason, you're probably not the ones to prescribe it, but just so you are aware, Seroquel or quetiapine is going to be like the preferred medication from our perspective because it has the lowest placental passage rate, and then also the exposure through nursing is the lowest. And so we try and use that medication if able. The caveat, though, is going to be like if someone has known bipolar disorder or schizophrenia and as a very high risk, we might just need to use what got them well, and we're not going to necessarily switch them to Seroquel because of that. But we prefer that medication if able. If a benzodiazepine is needed in pregnancy or lactation, the preferred medication is going to be lorazepam. The caveat to that is there has been more data lately that it increases the risk of miscarriage. And then in lactation, obviously sedation in the infant, it would be something that we look for. Just a quick note on lithium. I think a lot of historically it was a no in pregnancy. That's not how we feel about it now. If that's the medication that gets someone well, someone has no bipolar illness, that has significant risk, we're just going to talk to them about the risk of Epstein's anomaly. The risk is still low, but it is increased from the baseline risk. There is importance in coordinating with psychiatry at time of delivery because there is a little bit of mixed recommendations if the dose should be held. So if someone is on lithium, I think coordinating with psychiatry is important. And then also, I guess, to back up, making sure that they get appropriate like fetal ultrasound and whatnot at 16 to 20 weeks, fetal cardiac ultrasound as well, to look for that Epstein's anomaly. It is a medication that is controversial in nursing. Technically, it's not an absolute contraindication, but if I have a patient on lithium with bipolar disorder, I am likely going to tell them breastfeeding really puts them at risk for destabilization as far as their sleep. And so to really consider maybe not nursing, which is really hard conversation to have with people, but sleep is just so vital for people with bipolar illness. And then also it requires a lot of monitoring in the infant, like babies getting poked for levels and all of these things. So it probably doesn't make a lot of sense. But that's something that, conversations can be had about. To make things a little bit more complicated though, as in the ACOG recommendations to screen for bipolar disorder. So I believe on the ACOG website, which is really wonderful, it has like all these different screeners. It has the MDQ that's available, which does screen for bipolar illness. The caveat to the MDQ is that I think people screen for that and then it might show positive on the MDQ. However, it might be reflective of a lot of trauma or a lot of personality traits. So it doesn't necessarily mean that person has bipolar disorder, but maybe we think about it a little bit more closely. Maybe we make sure we refer to psychiatry to get them to weigh in about bipolar disorder, if that could be an accurate diagnosis, because it does change management. And I think that that's also what's really important with the follow-up is that if there's any concern, for a potential bipolar disorder, having that follow-up at 4 to 6 weeks, whether with you or whether with primary care or psychiatry is so vital because it doesn't mean that you should withhold treatment, but at least following up, especially if you started an antidepressant, which is typically not a good idea in bipolar disorder, at least not without a mood stabilizer or an antipsychotic on board to help with mood stabilization. The tricky thing about bipolar disorder is that the average age of onset correlates to childbearing ages. So people might not have any history of bipolar disorder, but childbirth might be a precipitant for their first episode of hypomania or mania. And my best friend, she doesn't live in Iowa, but she's a midwife, and she told me that where she is being trained, they are very worried about the statistic that they've been recently taught that 1 in 4 individuals with positive screen for perinatal depression will be found later to have bipolar disorder. And so people now are very reluctant to maybe prescribe an antidepressant, not knowing like, is this patient going to be 1 in 4 that turns out to have bipolar disorder? But I don't want that to be something that prevents someone being treated for a depression episode if there's no signs of underlying bipolar disorder at this time. Um, so that gets a little bit tricky. Also, though, if someone has a positive suicidal screen, like what do we do with it, right? Like, because that maybe I think makes people scared to screen too. And unfortunately, like in busy like OB clinic settings, sometimes time is an issue too, right? Like you're seeing patients over and over again. But I think, you know, understanding that what is there any plan behind this, like thoughts of suicide? Because sometimes people might have these fleeting thoughts of wishing they were to go to sleep. And obviously, we don't want anyone to have those. But the risk does change if someone's like starting to think of a plan or a specific plan, like they are going to overdose on their medications or they are going, to go XYZ. Like they have really thought this out. That is very, very high risk and that needs attended to like that day, probably even like warm handoff from the OB visit to a higher level of care. The same thing goes with intent. So sometimes people might have a plan, but they have no intent to act on it. And so it does change the risk a little bit. Still, though, getting them in the right hands of like to ensure safety is very important. And so if there's ever like plan or intent, immediate further assessment is warranted. And that would typically be like in an emergency situation. So it's not really like giving a referral to psychiatry or giving a referral to primary care at that time, more so getting them cared now. And so that does require a little bit more time to kind of try and figure out what the patient is actually thinking about. And also a lot of times getting collateral information. So like if a spouse or a partner or a friend is present, that can also be helpful with is the acuity needing to go to the emergency room now, or can we safety plan and ensure that there's a good plan in place to get to that follow-up appointment in like tomorrow or the next few days. Just a quick touch on postpartum psychosis. This is an emergency. I think sometimes we get referrals that are alluding to potential concern for postpartum psychosis, but we are happy to see them in the outpatient clinic. However, they really should have been evaluated immediately by the emergency room. So if there is any concern for postpartum psychosis, recommending like immediate urgent treatment or evaluation is appropriate. And so just a quick thing on that. The highest risk period is going to be days to weeks postpartum, although we do see postpartum psychosis developing later, but that's like textbook postpartum psychosis is it's very acute in the postpartum period. And it almost looks like delirium for some people. Like they're almost coming like in and out of reality. Like it's waxing and waning. Like they might be okay. And then all of a sudden they start making like some bizarre comments and then they're okay. And so those are warning signs. And obviously if they're hearing like any voices, they're really paranoid about like their partner, their family, things like that. That is very concerning. And also if they're expressing any like suicidal ideation, homicidal ideation, that's also incredibly concerning because with postpartum psychosis, oftentimes they feel that this is like they're helping by engaging on these things. So that just immediate warrant attention. So, or immediate attention. These are some of those resources for providers that I think are really helpful. So let's say you have a positive screen, but you still don't know what to do. There is a perinatal psychiatric consult line through Postpartum Support International. It is not like immediate, but you can call in and then typically someone will give you a call back. And so that's a really good resource to have. There's quite a few apps or websites that can be helpful with like lactation. And then, like I said earlier, the ACOG practice guidelines are phenomenal. Like they're really good. So those are great. They have the screening forms attached to that. There is through Mass Gen Hospital, which at least in my eyes, it's one of like the most robust places for information. They hold like a virtual round so you can attend. They used to be on Wednesdays. I don't know if they're still on Wednesdays. You can attend and ask questions to the experts in the field, which can be super helpful. And then this MICPAP for moms is also through Massachusetts. Unfortunately, Iowa doesn't have a perinatal access program, but they have some good stuff available that could be used for Iowa. And then hopefully someday in the future, Iowa will have a perinatal access program as well. And then I obviously this is through the University of Iowa. The University of Iowa has a wonderful women's wellness and counseling service where I did some training and is really great. I know Dr. Kopelman is in the Iowa City area. Broadlawns here has a perinatal clinic. So we can always refer patients there. There's also probably many other providers that I'm unaware of. We also use like Postpartum Support International, which has like online virtual support groups, peer mentor programs, a helpline. I give patients a national maternal mental health hotline at every visit. And then I also make sure that they're aware of like crisis lines and things like that or emergent needs. So that's all I have for the didactics.